This is Craig Bolger from the Department of Emergency Medicine at Ohio State University Wexner Medical Center. Today we will be covering basic obstetrical and GYN ultrasound. First, we will cover indications. In general, for point-of-care ultrasound, our indications are to confirm intrauterine pregnancy, assess fetal viability, and if the patient is already pregnant and presents with abdominal pain, trauma, or vaginal bleeding, we will perform an ultrasound to assess continued viability of the fetus. Other indications for performing a transvaginal or transabdominal ultrasound include concern for ovarian cyst or torsion, fibroids, persistent vaginal bleeding, and other pelvic concerns. However, those are outside the scope of most point-of-care ultrasound practice. To begin, we will have the patient supine. For all exams, we will start with the transabdominal approach. For this approach, the curvilinear or phased array probe can be used. In addition, we want a full bladder as to provide a good window to visualize the uterus. If we are unable to visualize the target transabdominally, the provider can consider performing a transvaginal approach with the endoluminal ultrasound. For this approach, the provider should have the patient empty their bladder prior to the exam. To begin, we will start with the transabdominal suprapubic approach. This is much like the subxiphoid view for cardiac. The transducer indicator or leading edge will be towards the patient's right. The provider will be deep in the pelvis and then flatten the probe against the stomach to interrogate the entirety of the pelvis, from the bladder to the uterus and the posterior cul-de-sac. The bladder will be seen in the near field and is usually slightly square-shaped with rounded edges and very anechoic with posterior acoustic enhancement, as seen here by the bright white posterior wall. In the far field, you can see the cervix with the os and the vaginal vault. The uterus typically wraps around the bladder. For the long axis, we will rotate the probe 90 degrees with the leading edge towards the patient's head. We will then rock the probe into the pelvis and then fan side to side, interrogating the uterus and bladder from right to left. For the sagittal anatomy, there are two potential spaces where we will look for free fluid, especially when concerned about ruptured ectopic, ruptured ovarian cyst, or trauma. For this view, the leading edge again will be towards the head. The bladder will be anterior and inferior, and the uterus will wrap around the bladder, with the fundus of the uterus here, the endometrial stripe, the cervix, and the vaginal vault. Occasionally an air-filled rectum can be seen in the far field. The two potential spaces are the rectouterine pouch and the vesiculouterine pouch, where fluid can collect. For the transvaginal exam, we will empty the bladder and use the endoluminal probe. We will hold the endoluminal probe with our finger as if on a trigger of a gun. The leading edge will be facing towards the anterior abdomen. We will gently insert the probe into the vaginal vault, fan the probe left to right to interrogate the uterus in the entirety of its axis from left to right, and then rock the probe to ensure that we are interrogating the entirety of the posterior cul-de-sac. So left to right, and then anterior and posterior. When we enter for the transvaginal ultrasound, the first thing the provider will encounter is the cervix. The bladder will be balloon-shaped and pointing towards the cervix. The posterior cul-de-sac will be visualized just posterior to it. Occasionally, the provider may see this image. This is a retroflexed uterus. Unlike the previous image, the cervix is now on the leading edge and much more anterior as the retroflex uterus falls posterior. Once we get to the adnexa, the provider will look for the ovaries. The ovaries are classically sandwiched between the uterus and the iliac vessels. The ovary will have a chocolate chip cookie or follicular appearance, and depending on the patient's point in the menstrual cycle, may have a large cyst attached to it. When color flow is applied to the ovary, a large ring of fire will be seen for the vasculature. For the transverse approach, the provider will rotate the probe 90 degrees with the leading edge now towards the patient's right thigh. They will then fan anterior and posterior, interrogating the entire axis of the uterus, and then rock to the left and then back to the right, fanning anterior and posterior to interrogate the adnexa. While the scope of the scan is to identify an IUP and investigate for fetal viability, if free fluid is seen or an adnexal mass is seen, this should prompt further workup. The first reliable sign of pregnancy will be a decidual reaction. This is the hypoechoic rim that we see in pregnancy. The first reliable sign of an intrauterine pregnancy is a yolk sac, as seen here in this faint rim. This will appear by about 4 to 5 weeks. Notice that this fetus is being captured by a curvilinear probe. Following a yolk sac, the provider will be able to see a fetal pole. This occurs around 5 to 6 weeks of gestational age. Next, the fetal pole will develop heart tones, as seen here by the small flicker. Note that from here to here is the fetal pole with the yolk sac just adjacent to it. This is important when obtaining measurements, as we do not want to include yolk sac in the measurement of crown rump length, as that will drastically overestimate the estimated gestational age. Remember that gestational age is most accurate in the first trimester of pregnancy. Occasionally you will see a white rim around the fetus. This is the amnion. As seen here, we have baby's head, torso, limbs, the gestational sac, and the amnion. In summary, it is important to keep in mind your scope of practice and your current practice environment when performing an obstetrical ultrasound. In general, bedside ultrasound is used to confirm IUP and confirm viability. Occasionally, in offices such as MFM, maternal fetal medicine, and some obstetrical offices, anatomy scans will be done. However, this is not typical of most focused bedside ultrasound. Remember that beta HCG levels can guide your scan, but should not be used in isolation. A general rule of thumb is that a beta quant of 2,000 or greater should be consistent with a bedside IUP. However, remember that beta quants have a fairly large range for each gestational age, and therefore cannot be used in isolation, but rather should be trended for the individual patient. When performing scans, make sure to look in the two potential spaces, the rectouterine pouch and the vesiculouterine pouch, for free fluid. Always start transabdominally when interrogating the pelvis, as you may be able to see more than you expect. And be conservative with your diagnosis and treatment. If there is not an IUP and the patient is hemodynamically stable, consider either a comprehensive ultrasound or allowing the patient to have a watch and wait period where they may return for further symptoms and have a repeat ultrasound and repeat beta HCG at a week. Please be very cautious when counseling patients and when doing your scan that you are considerate of the patient's needs and feelings. This includes using scripts, counseling the patient prior to your scan about the scope, and giving them warning about your counseling before the scan is done. For example, I tell every pregnant patient before I do their scan, if they present with abdominal pain and bleeding, that regardless of what I find, and no matter how reassuring it is, I will likely diagnose them with a threatened miscarriage. This allows them to find comfort in the fact that I have not seen anything on my ultrasound that caused me to place that diagnosis. In addition, I tell them it is not my job to decide if baby is normal, but rather to confirm baby's location and if baby has a viable heartbeat. Finally is safety. Keepsake ultrasound and repeat scans during pregnancy have not been shown to be harmful. However, it is strongly recommended that these are not performed and that ultrasound is only used if medically necessary. When possible, avoid color, pulse wave, and power Doppler, as these have higher energies and have theoretical threats to the health of the baby.